The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day to you, or good evening, or good morning. We're here for the next episode of TMD Demystified, and I am Tony Urbanek. Welcome. Today, we're going to talk about how to differentiate for your benefit, for your patient's benefit, or anyone else who is interested in benefiting from the solution to temporomandibular joint disorder, how to determine what treatment or process works the best or is the best. This opens up a lot of discussion, maybe a lot of disagreement, and that's why I'm here to kind of stir the pot, to have you take an honest look and confront the actual your actual experience and your level of knowledge about this problem. So let me go on and explain. After 46 years as an oral and maxillofacial surgeon and 11 years devoting my career primarily to the non-surgical treatment of TMD, I have become aware that there are multiple doctors and multiple providers who feel that they have the solution, the best solution in their hands for the treatment of people who have the symptoms of temporomandibular joint disorder. That's a given. I don't argue that point at all. I read about those individuals. I talk to those individuals. Most of them don't want to talk to me. Even though I reach out, I'm open to discuss anything about any topic with anybody. That is a fact of my career, but specifically, I am very interested in talking about with anyone the issues of TMD, but it's a highly emotionally charged area, I have found. While I did surgery for temporomandibular joint surgery, while I did surgery as an oral and maxillofacial surgeon for the better part of 30 years, I didn't feel emotionally charged about discussing the issue with anyone who had a disagreement as to how best to treat it, even then. But when I decided not to treat TMD patients with surgical intervention any longer, I found that talking to others who felt that they had a solution or had the solution for temporomandibular joint disorder, it was a highly charged area and confrontational, to say the least. I think I mentioned in a previous episode somewhere up the line that I actually witnessed, doctors, oral and maxillofacial surgeons with dental degrees and medical degrees who limited their practice primarily to treating TMD surgically, or did quite a bit, if they didn't limit their practice, did extreme amounts of surgery for temporomandibular joint disorders, who were a member of the temporomandibular joint disorder subsection of the American Association of Oral and Maxillofacial Surgeons, basically had their own organization within the oral and maxillofacial surgeons, who would almost come to blows, literally, in their disagreements with how best to treat TMD problems surgically, and they would get quite agitated, some of them, these doctors, within the meeting. So the point is, this is a very highly charged area, and on a higher level, I understand it. on a higher level, I do understand how people who think they have the solution or they have something that they prefer, and they feel they're right. And it's not my position or intention to try to make anybody else wrong. But when you bring up points that are factual and you can show factual information and it ends up making another person wrong, and this applies to anybody, you don't have to be a doctor, you make another person wrong, and more than likely they're going to become agitated one way or another. It's the rare person who can be made wrong and they go, you know what, I was wrong. You know, I see it. I mean, I was wrong. Thanks for bringing that to my attention. That's not the usual and customary. Most people, and particular doctors who have spent huge amounts of time on their education, it's doesn't usually work that way. All right, so that's my experience. That's what the features are that I'm going to discuss today. But what I want to discuss, and I want to bring out this without trying to, be too confrontational about it, try to ease into this thing, is that there are many providers who feel that their particular solution to treating people with the symptoms of headache, earaches is the only option. And the symptoms, again, of TMD are combination of any one or all of the following symptoms: headache, frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in your ears, feeling of fullness in your ears, subjective hearing loss, vertigo, dizziness, upper shoulder or upper back pain, either unilateral or bilateral, arm, hand, finger tingling and numbness, and various kinds of locking. Those are the well-accepted, well, at least in my practice, experienced all the time, but well-accepted symptoms associated with TMD. So because those symptoms are so diffuse, patients end up originally at many kinds of doctors. They may start out at a chiropractor or their PCP or a walk-in clinic or a neurologist with neck pain or headache, a orthopedic surgeon with upper shoulder pain. But these symptoms are extremely common with TMD, and my prior episodes explain to you why and how inflammation within this joint can actually create those symptoms. And we're not going to go into that. That'd be another episode or two to go through it again. But anatomically, physiologically, neurologically, inflammation in this joint signals the central nervous system that there's inflammation, and the central nervous system signals tighten up. And when it tightens up the jaw muscles and then the neck muscles and then the shoulder muscles, these symptoms appear. And they appear where the muscle attached to the bone, and that's where you get the pain. Ringing, fullness, dizziness is a separate item, and those were covered in recent episodes. But because those symptoms are so diffuse and dispersed, many different kinds of providers see these patients and try many different kinds of treatments. So how does one determine, whether it be patient or provider, doctor, well-intentioned provider, trying to figure out what is the best treatment option for patients with one or more of these symptoms that I enumerated? So it's not theory, that it is fact that the temporomandibular joint, once damaged, becomes inflamed. Inflammation of the temporomandibular joint is the definition of TMJ/TMD. Let me give you that again. It's been mentioned in other episodes, but let me give it again in this episode, because going down the logical progression that I'm attempting to do today, you have to start out at the beginning of the anatomy, physiology of the whole problem. And the whole problem is focused around the linchpin of the entire TMD conundrum is inflammation within the temporomandibular joint. inflammation within the temporomandibular joint signals and begins the domino effect of creating all of the aforementioned referenced symptoms. So the definition of TMD, TMJ starts with inflammation within the joint. And you can easily determine if the joint is inflamed by having the patient open widely, close rapidly with your fingers in the depression. And if it hurts, there's inflammation. So it's not hard to diagnose, easy to diagnose, along with the symptoms. And if it hurts, if the joint's inflamed, and if the joint's inflamed, you have the definition now, the diagnosis of TMD, inflammation within the temporomandibular joint. Okay, so with that as a starting point, the real question as to what is the best solution for treating TMD? And I'm going to run down, I made a brief list, and again, I did it in just a minute, of what is out there for what practitioners, both physician practitioners, medical practitioners, and dental practitioners, and chiropractic practitioners use, to my knowledge, for some or many of these symptoms. And the question is, do those particular services or procedures, do they actually have anything to do with correcting, modifying, or mitigating inflammation within the temporomandibular joint? Because the point is, if a provider, a doctor or person can have a service which decreases the inflammation within the temporomandibular joint, the symptoms will diminish. That is what we've proven. That is what we've proven by independent university study. That's what we've proven by treating over 4,000 people here in this practice. And that is what is being proven on a day-to-day basis by our increasing number of doctors who are network providers throughout the United States, who do nothing more and nothing less than decrease inflammation within the temporomandibular joint. And how do they do that? Well, we'll talk about that at the end, but that is what they do. That is what we do. That is what my practice does. Decreases inflammation within the temporomandibular joint. And we'll talk about how we do that, but I guess those of you who are watching this, you already know. But let's talk about what else is out there. So the question and the purpose of this episode is to compare and contrast those services or devices or whatever that are being used to treat those symptoms, and what effect, if any, do they have on decreasing inflammation. All right, so let's start out with drugs. We know, and I mentioned this before, non-steroidal anti-inflammatories, meaning drugs which decrease inflammation, work pretty good on these joints or any other joint or any other area of the body or damage to the body that is inflamed. That is their purpose. Non-steroidal anti-inflammatories, which basically are known as aspirin, Tylenol, or Motrin by their trade names. Those are the most common trade names of the anti-inflammatories. And they work really well for a short period of time. That is why people with knee problems or elbow problems, or they'll take a couple Motrin and they'll find pretty quick relief, because Motrin decreases the release of prostaglandins, which decreases the inflammation, which makes it feel better. But the problem with non-steroidals is they only are effective for a short period of time, in the lengthy period of time. I mean, they'll be effective immediately for an hour, 2 or 3, but the point is, if you keep using them, they run out of steam. The body acclimates to the constant use of these drugs, and within a week or 2 or 3, you can take huge numbers or quantities of non-steroidal anti-inflammatories, and they will not be effective. Their only effect then will be to stimulate gastritis and give you stomach pain. And if you take them long enough, they can significantly damage your liver or your kidneys. Well known, well documented. There are a lot of studies on that, a lot of information on that on the internet. So that's not a good long-term solution. And most people, in fact, all the people that we see with this problem have long since been burned out on using non-steroidal anti-inflammatories. So that is somewhat effective in the early stages or the early part of this, but you can't take them long-term, and they're effective if they're only a short period of time, 2 or 3 weeks. So not a good long-term treatment. The next one that comes up is, and I'm questioning this, is compare and contrast. If we start out with the knowledge that all the symptoms are directly related and come from inflammation within the joint itself, what these other modes of treatment are, what effect they have on inflammation. So the next one is Botox. That's pretty simple to, Botox paralyzes muscles. And if the muscle is tight, it pulls on the bone, and where it pulls on the bone, it stimulates the nociceptors, and that's where it hurts. So people that have this muscle called the temporalis on the side of the head, when it gets tight, it pulls on the bone and it hurts right up here, and patients will come in and say, "Doc, it hurts right there every morning." And if you Botox that muscle, it'll paralyze that muscle and make this side of your face, and make it'll make these go away nicely. And if that's what you're doing it for, good luck. It's a good service. You want to make your lines go away, Botox it, but you got to do both sides or it kind of look funny. But what effect does that Botox have on inflammation within the temporomandibular joint? None. And that's just a fact. So lots of doctors are charging a lot of bucks, and I see it every day. I had one yesterday, unfortunately, and she used a lot of Botox and was in my office with a whole bunch of symptoms, and was still taking Botox and had all these symptoms and didn't know what to do. Physical therapy on the muscles, on the joints. What effect does that have on inflammation within the temporomandibular joint? We know that overuse of the joint itself is what causes the inflammation. Bruxism, clenching and grinding, acute trauma like auto accidents, whiplash, and then functional malocclusions where your teeth don't meet together and overloads, and your teeth don't meet together correctly to the degree that it's a functional malocclusion, and that overloads the joint. So those are the 3 circumstances that overload the joint that create this inflammation. So again, physical therapy by manipulating the neck or manipulating the shoulders where it hurts, or manipulating the jaw, what effect does that have on the inflammation within the joint? And we see it all the time. I mean, patients come in with neck pain or upper shoulder pain, and they've been to the physical therapist, and they get the pain in the shoulder because those muscles get the signal from the central nervous system when there's inflammation in the joint to tighten up. So the physical therapist will go ahead and do physical therapy of one method or another, and there are multiple for muscles of the upper shoulder and upper back, and get those muscles to relax. That is effective in relaxing muscles for a time, but it doesn't do anything to the cause or the common denominator, or the first domino of all, however you want to look at it, the first domino of all the dominoes. So patients will report they went to the physical therapist and they had a whole series of physical therapy, and they had multiple treatments, 5 treatments, and it felt good for a while afterwards. And after a while, it started to hurt again because that therapy did not affect the inflammation within the joint itself. All right, next up on the list is occlusal equilibration. We see a lot of that. In fact, one of the best known textbooks, I will leave it unnamed, but one of the best known textbooks in the United States of America, with multiple editions. The last 4 chapters or whatever goes into great detail about how to properly either reconstruct or equilibrate the occlusion for the treatment of TMD. So we do know that a functional malocclusion, when your teeth don't meet together evenly, can actually create damage within the joint. No doubt about it. That's one of the three circumstances that I mentioned: bruxism, acute trauma, and functional malocclusion are the only 3 circumstances that actually create damage within the joint, which causes then inflammation. But occlusal equilibration doesn't do anything directly to inflammation within the joint. So I would assume, and I actually have observed in some cases, equilibrating the occlusion will take off or remove enough of the disocclusion or malocclusion that it does not put any further damage to the joint. And in some cases, the inflammation will die down. If you're not continuing to incite inflammation or cause inflammation within the joint, eventually that inflammation will diminish and the inflammation will go down. But in many cases, you can have a perfect bite that is perfectly occlusally equilibrated, but the inflammation in the joint is coming from one of the other causes, or even the cause of inflammation that originated from the occlusion, but the inflammation, the damage is already done, and the inflammation continues even though the bite has been corrected. At which point the solution is to unload the joint, and then the inflammation. An unloaded joint, the inflammation will naturally diminish, go down. So occlusal equilibration has some value in some cases, but will not fix damage from an acute damage to the joint. And it certainly doesn't do anything in stopping bruxism, because bruxism is a problem we do not fully understand. In fact, we understand very little, if anything, about bruxism. The only thing we understand about bruxism, it's related to stress. The more people brux. We don't understand the mechanism. There are a bunch of theories out there, but we do not, no one can say we know the mechanism for bruxism and exactly how it works. We know it's related to stress. So by occlusal equilibration, you're totally missing at least 2 of the causes which damage the joint and create the inflammation. The next is one that I see frequently. People go to massage therapists, their muscles hurt. Actually, the muscles don't hurt. It hurts where the muscles attach to the bone, but when you get the muscle to relax, it doesn't pull on the bone anymore. Therefore, the pain goes away. That's how massage therapy is effective, and it is effective for short periods of time, but you got to go back and do it frequently. And if that's your only symptom, which is my upper back hurts or my shoulder hurts, and you want to go through a massage therapist frequently, and every time the muscles get tight, because the signal continues, if the joint's inflamed, the signal continues to come into the central nervous system, into the brainstem, and the brainstem says, I acknowledge that your joint is inflamed. I'm going to help you out, tighten up the muscles. So you go to the massage therapist, and they massage that muscle till it finally relaxes, which feels really good. And it doesn't pull on the bone, and the pain goes away, but the signal continues to come down. And within a period of time, whether it be a day or a week or a month, that muscle will again get the signal to tighten up. And now you're back to, it hurts again. I need to go back to the massage therapist and get some more treatment. And if that's your preference, go for it. But the point is, what does massage therapy have to do with decreasing inflammation within the temporomandibular joint? Nothing. Doesn't happen. Then there's some things that are on the table that have been used kind of infrequently. TENS units. TENS units are units would put a low current through a muscle to relax the muscle. Same concept. You can relax a muscle with a TENS unit. The muscle then relaxes, quits pulling on the bone, pain goes away, but a TENS unit does not have any effect on decreasing inflammation within the temporomandibular joint. The general catch-all of myofunctional therapy, which is different machines and mechanisms to address the muscles themselves. Again, the muscles are constantly getting these signals, and the signals vary. They can be on the right side of the face, the left side of the face, the neck. The next morning, it'll be the shoulder, then it goes back to the head, and patients report this all the time. Sometimes it hurts here, sometimes it hurts here. That is why our physician colleagues, when they get patients in with these symptoms, just shake their head and say, and not infrequently tell the patients, it just makes no sense to me. I mean, I think you're crazy because I've never heard of anything like this. When actually, it is simply explained by the inflammation within the temporomandibular joint, constantly sending out various signals to various muscles at various times to tighten up. And that explains the majority of the muscle pain, which is actually bone pain, stimulated by muscles pulling on the bone. So myofunctional therapy doesn't have anything to do with decreasing inflammation in the joint. Orthodontics, that's coming up next. Kind of the same thing as equilibration and occlusal reconstruction. If the inciting factor for temporomandibular joint inflammation is a functional malocclusion, there is some benefit to going to the orthodontist and having the orthodontist get your teeth straight. That is not the issue. The orthodontist must get the occlusion, the jaws, to match so that there isn't any significant difference between centric occlusion, bite 1, and centric relation, bite 2, where the ball fits in the socket of the joint. And most orthodontists, in my experience, don't aim for that. They do not consider that as the goal of orthodontists. The goal of the orthodontist is to get straight teeth, and for the most part, disregard where the jaw sits. That is a fact. But in some cases, an orthodontist can unload the joint long enough and significantly enough that the inflammation dies down. When the inflammation dies down, the symptoms go away. However, in some of those cases, enough damage had already been done to the joint, and the inflammation will not decrease, even though the teeth now fit together very nicely, and the patient continues to have symptoms of headache, earache, jaw pain, etc. This is well experienced and well seen on the patients who have significant jaw growth problems, big jaws where the lower jaw sits out in front of the upper jaw, or it sits way in back of the upper jaw, class 2 or class 3, where the patient actually needed jaw surgery, orthognathic surgery, in addition to orthodontics, to get the jaws in position so they didn't overload the joint. In my experience, I want to bring this out, it's pretty much consistent right down the line over the years, is that we see, because of my experience as an oromaxillofacial surgeon and doing literally thousands of cases of orthognathic surgery, and seeing the effect on the temporomandibular joint in patients and temporomandibular joint symptoms, what we found is that once a patient goes through the orthognathic surgical orthodontic series of events, orthodontics and surgery, half of them will unload the joint adequately where the inflammation dies down, and that's all we have to do. And half of them need to go through the use of an intraoral disoccluding splint, the urbanic device, and protocol to unload the joint. So after orthognathic treatment, orthognathic surgery, we find that half of the patients, that's all we have to do. And they come back and they say, my symptoms are diminished, and I don't have any more headaches and neck pain and ringing in my ears. And half come back and they say my symptoms are continuing, at which point we put them in a device and protocol to unload the joint. And at that point, then their symptoms of TMD will diminish and decrease. And I think those are the ones that came to the top of my mind. There are other treatments, for sure, more machines that are applied to the head and the neck, and different things for the symptoms of well-known symptoms of TMD. But those are the ones that are most common, at least in my mind. And they are, I think, some of the most common out there for treating TMD. And the question is that you should ask either as a patient or a provider. And I'm surprised to learn that patients have access to these episodes. I did not think of that when I first started this podcast on Dental Town, that of course patients have access to it if they want it. And I have had patients, I mentioned one before recently, who came from Dallas, Texas to see us. And she had actually, by her own admission, watched, she said, every episode of this podcast. And kudos to her. But to the doctors out there, I think that you do need to ask the question as to what you are doing or think is the right thing to do, or want to do, or have heard is the right thing to do, or read the right thing in an article or a textbook to do. The question, the proper question to ask is, whatever that treatment or service for any of the symptoms of TMD, the question to ask is, does that have a significant effect on decreasing inflammation within the temporomandibular joint over a long period of time, over a consistent and long period of time? And so here's the commercial. What we found is that placing an intraoral device that separates the posterior teeth initially, and just for the first 2 months to get the inflammation on its way down significantly, and then nighttime only after that, is a significant improvement and has a significant ability to consistently, over the long term, decrease inflammation within the temporomandibular joint. Unloading a joint, knee, hip, elbow, unloading a joint long enough on any joint will allow inflammation to die down. If you have a bad knee, just walk around on crutches for a while and your knee will quit hurting. You've taken the load off the joint, the inflammation goes away, the pain goes away. And that is what we do with the Urbanic device and protocol. We unload the temporomandibular joint initially, rapidly, 24/7 over the first 2 months, and then nighttime after that, indefinitely. And that works pretty well. It's proven by independent university study. It's proven by our 4,000 people. And I have now connected the dots and shown through that's described on these previous episodes of actually how that works anatomically, physiologically, factually. So when you are considering what is the appropriate treatment or treatment plan to use, the question you need to ask yourself is, does it decrease inflammation within the temporomandibular joint, and for how long? And is it easy to do, or is it complicated to do? Does it have risks with it? What are the risks? So that is my statement and presentation for today. And I would encourage anyone who has any criticism or comment to contact me. I'll be happy to discuss it with you, further explain it, send you information, because I am completely, and we are completely transparent about what we found out and our facts as to how to treat this, which, as I've talked about many times before, is not consistent with the establishment. And I find that to be the case. And that probably would be a good title for another episode. It's like TMD in the establishment. But again, I'm not out to call out anyone in particular. I am out to, we have solved this problem, and I'm out to demonstrate it. And I have taken it as a personal challenge to bring it to as many people as possible who really need this service to get rid of the 10, 20, 30 and more years of symptoms that they have been suffering significantly because the problem itself has been misdiagnosed, or it has been mistreated, or it has been misdirected. And I stand by that. So for today, I hope you think a little bit about what I tried to impart today. I hope it makes sense to you. I certainly hope it makes sense, because I tell my patients all the time, half of my job is to fix you, but the other half is to explain to you what's going on so you understand it. You know, half my job is education to the patients, and I spend half my time educating patients. And I tell them all the time, half of my job is to get you to understand this problem to the point where it makes sense to you what I'm speaking, it makes sense to you what I'm describing, makes sense to you. And if once I make sense to you, then you will understand how we treat it, why we treat it, why we have such good results. And then half my job is to actually treat it and get those results. That's what I say every day, literally every day in this practice. And my associate, Dr. Urbina, also states. And I hope the network providers who are already in our network treat it that way too. Half your job is to educate the patients so they actually understand what you're doing. It makes your job much easier, and it makes the patient much more happy when they understand what's going on. So enough for today. I appreciate your time. I appreciate your attention. And until next time, which will be next week, we'll pick another topic and we will develop another episode for our podcast, TMT Demystified.